Audio Jungle.
Hello, my name's Penny Tuffin. I'm an Advanced Practice Pharmacist, and today we're going to be talking about managing nausea and vomiting in people with palliative care needs. There's lots of different causes for nausea and vomiting across people in the general population, but also in people with palliative care needs. Commonly, we see people who are constipated or have slowing of their gastrointestinal transit. They may have liver disease, they may have infections or medication that can cause slowing of the gut. People with biochemical abnormalities, particularly as they're in their advanced stages of the disease, are quite common. Movement can cause nausea and vomiting, as can therapies like chemotherapy and radiotherapy, and some people may have raised intracranial pressure, particularly if they have brain metastases or brain cancer. I find this diagram quite useful. It's quite old, was produced by Twycross in the 1980s, but it gives a little bit of an indication of what the common modalities of nausea and vomiting are in people with palliative care needs. So if you look at the top half of that pie graph, all of those two causes are biointestinal slowing of the gut. So therefore about half the nausea and vomiting within people with palliative care needs is induced because their gut is working much slower than a normal person's might be. There's about a sixth of nausea and vomiting that's caused by biochemical abnormality, another sixth by medication, and then about 5% generally because of raised intracranial pressure. And then the other little slice there is a whole lot of mixed etiologies. So when we're looking at treating nausea and vomiting in palliative care, we need to do a really clear assessment. And there's lots of things that are going to be useful in us trying to determine the cause and determine what medications and what modalities of treatment are going to be most useful. So we want to know when it started, how long it's been going for, how bad it is, whether it is nausea, whether it is just vomiting, whether it is nausea and vomiting, because we will treat those differently. We want to have some idea of the frequency and the timing. For instance, is it just after meals? We want to have a bit of an idea about what they think makes it worse. So is it when they get up and move around that they feel worse? And we want to know also if there's particular medications or other things they have tried that have actually made their nausea or vomiting better. We will always do a medication review because medications are a common cause of nausea and vomiting in people. And we want to look at the character, whether it's projectile, which will mean that it's probably got a central cause as opposed to a normal nausea picture that we might see in somebody else. We want to look at whether there's any precipitating factors. So that will be maybe we check their biochemistry to look for things like renal dysfunction or look to high levels of calcium, for instance, in their blood. So the general principles of managing nausea and vomiting are that we try and determine what we think are the underlying causes. We want to treat any underlying cause that we're able to. So for instance, if it's an infection, we might want to treat that. If we have biochemical abnormality, we might want to treat that. If it's due to constipation, we definitely want to treat that. We would give general advice and support, and I'll talk a bit more about that later on. And we also then want to prescribe the appropriate medication, and we'll choose the medication based on what we think is the cause and therefore what mechanism the nausea and vomiting is being precipitated by, and therefore what neurotransmitters are involved and what medication will modify how those neurotransmitters are being released. So the general advice and non-pharmacological methods that we will use include these. We need to have people with good oral hygiene. So making sure that their teeth are clean, they haven't got thrush, their mouth is moist, will all help with making someone feel less nauseated. We generally recommend frequent small meals, not just a great big plate full of meat and veggies. For dinner, the patient may actually prefer just to graze during the day rather than being presented with one big meal. Generally avoid smells and sight that are disturbing for the person, and that may be the smell of food cooking. For some people, they just find that really difficult to tolerate and feel really nauseated by that. So it might mean that they move to a different part of the house, or they go outside when meals are being cooked. Fresh air and a calm environment is always very useful in terms of just keeping the person in a good frame of mind and not making them feel like there's things that are stimulating their nausea and vomiting. And as a general recommendation, we should try and have people sitting upright after their meal so that the food can actually process through down to their gut appropriately. The mechanism of nausea and vomiting is quite complex, and I'm going to run through quite a simplified version of what happens to give us some idea of how we might choose which medications might be the most appropriate for different types of nausea and vomiting. So as you can see here, there's various different inputs into your vomiting centre, and then once the messages reach your vomiting centre, you then release a whole cascade of effect through your body, which will then stimulate you to vomit. So prior to you actually vomiting, you may feel nauseated or not, and the stimulation will come from various different places. So it may be your higher cortex centre, so your cerebellum. It may be through your balance centre or your vestibular centre. It may be through your chemoreceptor trigger zone, which is very responsive to changes in chemicals in your body. Or it may be from your stomach or small intestine, so when food is actually getting into that area and your body doesn't have the normal processes to process the food. All of those stimulate back to your vomiting centre, and there's other neurotransmitters in your vomiting centre that can be affected as well. And we'll go through each of these in turn. So when we're talking about the higher cortical centres being involved, we're talking about generally sensory input, and that might be from the smell, as I've already mentioned, the smell of food, for instance. Looking at things, pain can cause you to feel nauseated. Fear and anxiety also can stimulate the feeling of nausea. If we're looking at the chemoreceptor trigger zone, it's normally toxins that are affecting that, and so it'll be drugs are generally considered by your body to be a toxin, as is when your body becomes out of balance and your general biochemical balance is affected in some way, and that will then influence through your chemoreceptor trigger zone to make you feel nauseated or to vomit. Your small intestine is about movement of food through your small intestine, and that may be for a whole range of reasons. You may have had surgery, you may have disease in your small intestine, and so you can't transit food properly, and that will give stimulation back to your vomiting centre. And then we have our balance or vestibular centre, and that may be affected generally by movement. So the most common people can think about is seasickness or travel sickness. That is mediated through your vestibular centre, but for people who have lost lots of weight, their vestibular system might not be in quite the same balance as it would have been previously, and so they can feel quite nauseated when they're being moved. And then your vomiting centre, and this controls your actual vomiting reflex process. There can be various interactions that happen before you vomit, so you get pale, sweaty, you get extra saliva, and these are all moderated through your vomiting centre. For each of these centres, there's then neurotransmitters that are involved, and these affect in different ways the amount of neurotransmitter that's released. There's different balances within each centre, and these are mentioned here on this slide. So for your higher cortical centres, we're talking about things like GABA and serotonin. Your chemoreceptor trigger zone is mainly moderated by dopamine and serotonin. Your stomach and small intestine have acetylcholinergic, muscarinic, anticholinergic receptors, serotonin and dopamine receptors, whereas your vestibular centre is mainly moderated by histamine and has some acetylcholinergic input as well. And you can see your vomiting centre also has input. So when we're trying to decide by our assessment which of the centres may be involved, we're really trying to look at what neurotransmitters, as listed here, might be involved in nausea and vomiting, and that's what we might be able to moderate with medication. There's lots of different antiemetic drugs we can use. And we will talk about these individually to try and relate them back to the types of nausea and vomiting they'll be most effective in. We're also going to talk a little bit about the doses and the side effects that you might see for each of these sorts of nausea and vomiting. Metoclopramide is the most commonly prescribed antiemetic. It has dopamine antagonism and a high dose serotonin antagonism as well. But generally the doses that we're looking at for treating most nausea and vomiting, we're looking mainly at an effect on dopamine. It also has good prokinetic effect. So for patients who have palliative care needs who may have nausea and vomiting either because their gut is slowed or they have biochemical or drug-mediated nausea and vomiting, metoclopramide is going to be our first choice. And that is why generally in palliative care we see a lot of metoclopramide prescribed, because it generally is a good first choice and a good antiemetic for most types of nausea and vomiting. So metoclopramide, the general dose will be 10 milligrams 3 times a day, so roughly 8 hourly. Generally it's recommended it's given before food, but that is really only important if we know that it's a prokinetic. If it's a slowing of the gut, then we want to get the drug into the person before they have their food, so it's already working. If it's caused more by biochemical abnormalities or medication, it doesn't particularly matter in relation to food when we take the metoclopramide. The side effects that we see most commonly are sedation and extrapyramidal effects, and we need to monitor for these. There's a whole range of other side effects too that we may see with metoclopramide, ranging from diarrhea, depression, rashes, itchiness. So we need to always be monitoring for side effects. Metoclopramide is contraindicated if we have a complete bowel obstruction. So we don't want a drug that's going to be pushing and causing more peristalsis if we actually have actual blockage of the gut. And they're also contraindicated in Parkinson's disease because of the dopamine effect. So just to give a little refresher on what we mean by extrapyramidal effects, because it's very important. A lot of the medications we're using have dopamine effects. We can have acute dystonic reactions where we get within a couple of hours generally, patients will start to have facial spasm. They may have ocular gycrisis, and that is where they may get a stiffening and straightening back of the neck, and also their eyes might start rolling back. So it's a very obvious effect, but we need to always look for it. They may get an akathisia, which happens over a longer period of time. So just because a person hasn't had a reaction to a dopamine antagonist in the first couple of hours of therapy doesn't mean that they're going to be safe from any extrapyramidal effects. So that's where they might get a restlessness and they just can't sit still. It may be possible for patients to actually get Parkinsonian type symptoms, and that will happen after several weeks of therapy. And also tardive dyskinesia, which is less common in palliative care people because it generally occurs over several months of therapy. But we need to be very mindful of what these adverse effects are and look out for them. So let's move on to the next medication, and that's prochlorperazine. Prochlorperazine is a dopamine antagonist. It also is a partial histamine antagonist, and therefore it's going to be useful for any nausea and vomiting mediated through the chemoreceptor trigger zone, so any medication or biochemical abnormalities. But by having the antihistamine effect, it can also be useful for people who get vertigo or movement-induced nausea and vomiting as well. It comes in various different formulations, so it's available as oral, rectal or injectable forms. It's generally recommended that prochlorperazine isn't given subcutaneously because it can be quite irritant to the tissue, and it also has the same precaution with Parkinson's disease because of the extrapyramidal side effects. The doses are generally orally 5 milligrams TDS to 4 times a day. We give higher doses if we're giving it intramuscularly or intravenously. We should, though, however, try not to give it intramuscularly. Intravenous is going to be far more effective, but also not painful like an intramuscular injection. The most common side effect with prochlorperazine is drowsiness, but we can also see extrapyramidal effects. We can get hypertension, we can get confusion, and we can get anticholinergic effects as well. Haloperidol is another very common antiemetic used in palliative care. It is a stronger dopamine antagonist than any of our other agents that we use, and therefore it'll often be our second line. If we found that metoclopramide or prochlorperazine haven't worked, then we may use haloperidol for nausea and vomiting mediated by chemoreceptor trigger zone type causes. Doses are generally low. We'll start with 0.5 per milligram once or twice a day and move up to 1 milligram. The side effects are similar to the last two drugs I mentioned, so drowsiness, extrapyramidal effects, hypotension. Haloperidol also can cause some confusion or agitation, and we need to be looking out for that. In terms of its drowsiness, although it does happen, generally at these low doses, it is far less sedating than metoclopramide or prochlorperazine. It comes in oral and injectable forms and can be used subcutaneously. Domperidone is very, very similar to metoclopramide, except that it only becomes available in an oral formulation, and the most important note is that it doesn't cross the blood-brain barrier, so therefore it doesn't have extrapyramidal effects, making it one of the only antiemetics we have for controlling nausea and vomiting in people who have Parkinson's disease. The dose is similar to metoclopramide. We would generally start with 10 milligrams TDS, but we may move up as high as 20 milligrams QID. The side effects are very limited, and that makes it a very useful drug. However, because it's only available in oral formulation, it means that if someone's actively vomiting, it's not going to be useful because they're not going to be able to absorb the medication. So generally it'll be reserved for people who have nausea only. Then we have two antihistamine antiemetics, promethazine and cyclizine. Promethazine is generally more sedating than cyclizine, but both medications being antihistamines can cause sedation. The doses, promethazine is generally 10 to 25 milligrams BD, whereas cyclizine is 50 TDS. They're different types of medications, so the dosing is quite different, and we need to remember that. They're both available in oral or injectable forms, but promethazine can be quite irritant when given subcutaneously, so we need to be mindful of that. Cyclizine, however, is tolerated quite well subcutaneously, and it can be used in infusions as well. If it is used in a subcutaneous infusion, we need to dilute it with water rather than saline, because it will precipitate out when mixed with water. Ondansetron is an antiemetic that's used commonly, particularly in nausea and vomiting associated with chemotherapy and radiotherapy, and also post-operatively. And that's because it works on serotonin, and so it's very useful in those sort of situations where nausea and vomiting is because of the release of serotonin, generally because the body's under stress. However, it's not going to be useful generally for biochemical abnormalities or other medication-induced nausea and vomiting, because these don't have an effect on serotonin levels. Therefore, it generally won't be useful for opioid-induced nausea and vomiting, for instance. It does have a range of side effects. Headache and constipation are particularly troublesome, and are obviously not side effects that we want to see in patients with palliative care needs who are prone particularly to constipation because of other things as well. The dose is generally 4 to 8 milligrams twice a day. So to put all that into a summary, we can see that various different medications are going to be useful for various different causes of nausea and vomiting, and these are listed on this slide. So in summary, the medications that we're going to use are going to be dependent upon what we think is the cause of the nausea and vomiting, where we think it's being mediated, and therefore what neurotransmitters are involved. So if we're talking about sensations having input into the higher cortical centres, we're not going to specifically use antiemetics. We're going to use medications like dexamethasone and benzodiazepines to reduce the sensational input into those areas. When we're talking about nausea and vomiting induced through the chemoreceptor trigger zone, we'll be using medications that affect dopamine in particular. So we'll be talking about metoclopramide, prochlorperazine, domperidone, and haloperidol. If we're talking about increasing motility through the gut, we will be looking at metoclopramide and domperidone, our two prokinetic antiemetics. When we're talking about movement-induced nausea and vomiting, we'll be talking about the medications that affect histamine, so particularly promethazine and cyclizine, and prochlorperazine to a lesser extent, but it is still quite useful in that setting. If our first-line antiemetics haven't worked, then we can look at using medications that affect the vomiting centre, and generally that'll be antihistamines, so promethazine and cyclizine. So our basic principles for treating nausea and vomiting in people with palliative care needs are that if we've got nausea and vomiting present, we're generally going to want to use an antiemetic on a regular basis. So we would prescribe metoclopramide 10 milligrams TDS so that we can have medication in their system all the time, rather than prescribing on a PRN basis where we're not having that constant effect on the neurotransmitter. We will have a breakthrough antiemetic available as well in case in our assessment we haven't actually worked out what the major problem is for that person. So, for instance, if we've chosen metoclopramide as our first-line agent, thinking that it's mediated through the chemoreceptor trigger zone, we might choose haloperidol as our PRN medication as backup because it's a stronger agent. We need to reassess frequently because nausea and vomiting is a difficult symptom to assess and to work out the cause of, and so therefore we need to have ongoing assessment and being prepared to change our antiemetic or even use two antiemetics if we think there's input from two different causes. Thank you for watching the video today.
Audio Jungle. Audio Jungle. Audio Jungle.